subscribe. Good evening, SPSM. How are you? This is at Doc Foreman. It is Halloween. It's Halloween Eve? I don't know how this works.
Yeah, Hallows Eve. Hallows Eve. It's the eve of Hallows Eve.
It's Hallows Eve. Thank you, Bart. Here on SPSM, we're bringing it back. Everybody, we're going to be talking a lot about zero suicide, and we're going to be talking about how Centerstone is using data and innovative approaches to managing what's happening with their EHR data and their clinical processes to get a zero suicide rate. And I'm super excited to talk with you guys about that. Additionally, we have a special announcement that will occur at 50 minutes into the hour. So I'm kind of excited. You need to hang out for that because there's going to be some special news for this week. If you don't know who I am, I'm at Doc Foreman. I'm one of the founders and producers of the Suicide Prevention Social Media Chat, hashtag SPSM. If you are watching from the live stream, you can also follow along on Twitter. I want to shout out to some of the folks I know have been tuning in who are new to the chat, and to give you guys a big welcome. I want to introduce you to my co-host, Dr. Bart Andrews.
Good evening, everybody out in SPSM land. I am so excited about the show because the guest tonight has really been a mentor and a source of so much wisdom around zero suicide. And I'm gonna let April do the introduction. I'm not gonna say a lot, but my name is Dr. Bart Andrews. You can find me on Twitter at Bart Andrews. I'm at Behavioral Health Response, an amazing crisis agency in St. Louis, Missouri. And I'm really excited about this show tonight, and I'm really excited about our guest. You are going to love Becky Stoll.
Yeah, you don't get off this easy because this was one of those ones that you brought to the SPSM team's attention because of how exciting her stuff was. And we almost didn't get started on time because she was that exciting.
It was well, and she's got a promise that she's going to talk about a food baby because I was at a Zero Suicide Academy where Becky introduced the concept of food babies to me, and I love it, and the crowd loved it. And so at some point, Becky, you're gonna have to
you and Tony were having a great time with that you guys were having a great time with the food baby at last chat. Tell us a little bit about what got you excited about listening to Becky from Centerstone, and before we introduce her.
So one of the things, and this is, if folks don't know this, I'm going to say this out loud. Centerstone is at the cutting edge of the Zero Suicide Initiative in so many ways. And one of the things that when Missouri had its own Zero Suicide Academy, I wanted Becky to be there, and this is why. Becky is changing the culture about how we talk about suicide, particularly around agencies being able to talk about openly, this is what we're doing well, and this is what we need to get better at, and we had these deaths, or we had these hiccups. And I think one of the things that we have found across, it's really interesting, and I can share, I'll share this. So when we do Zero Suicide Academies, people do kind of they do a self-assessment. And healthcare clinics tend to rate themselves very accurately. Behavioral health clinics tend to rate themselves really, really high. And it's because they think they're supposed to be experts at this, and they're not, right? And getting folks to recognize that this is an area
So what do they rate themselves on?
All kinds of things that we do, or that you would do around a systemized approach to preventing suicide, right? So and so it was really interesting because it's so hard for behavioral health agencies to talk openly and honest. There's a sense of, if I do that, my liability is going to go up, or people are going to think I'm crappy at this. And so there's this culture about not talking about where we can be better. And one of the things that I just love about Becky, who's at this powerhouse agency, she's able to talk about the amazing things her agency does, but she's also able to have these really open, honest conversations about what they're doing well, what they're not doing well, what they want to be better at. And that is really changing the culture. And when we were in Jeff City last April, her ability to do that, you could tell the group, after Becky talked, the group started opening up a lot more about, well, yeah, we're not so good at that, and this is something we really need to look at, and we need to do, and that's creating those conversations is really powerful. And I'll tell you, that's one of the things about Zero Suicide I love. A few weeks after the Zero Suicide Academy, some of the agencies that weren't there heard about it because the agencies were talking about it, and somebody reached out to me, and they'd had 2 deaths at their agency in the last month or so. And here's what's interesting. Prior to Zero Suicide and talking about it, this agency would have done this alone. They would have said nothing to anybody. Nobody would have known about it. They would have kept it quiet, right? Because they were afraid that somehow that they're a bad agency because it happens, which isn't true. It's an amazing agency. And that's the sort of thing that's really, we're changing the culture, that we're able to talk about these things, and we should be talking about those things. And Becky models that so well. And it's just always a treat to watch her present. And that's why I was so excited about her being on the show tonight, because she's awesome.
So I'm really excited that Becky Stoll is here from Centerstone, and we're going to have her talk a little bit about who she is and share a little bit of the story of how Centerstone got involved with Zero Suicide. Another reason that I'm very excited is because I work at VA. We report our statistics about suicide at morning meeting every day, but there isn't always a great sense outside of VA, or even happen to know, like, between different VA medical centers, about consistent ways that we want to be looking at data about a healthcare system data about suicides. And so Becky started talking about this as we were getting ready to roll and hit the button live. And I was like, that is wonderful. This is, Centerstone really is leading the way, and they're doing so well that I probably overestimated how long they've been doing it. So I'm going to go ahead and turn the camera over to Becky. Becky, why don't you introduce yourself a little bit, tell people who you are, and tell people a little bit about how Centerstone became interested in Zero Suicide.
Well, thank you. Hello from Nashville, Tennessee, in my living room.
Hot chicken.
Absolutely. Hattie B's hot chicken. You can get Shut the Clock Up or Go Cluck Yourself. That's the levels of hotness. So I'm Centerstone's Vice President for Crisis and Disaster Management. And so by default, as we sat around a table in Indiana a few years ago, they were developing clinical pathways, which was really some clinical decision support for different disorders, depression and anxiety and substance abuse, things like that. And they really decided we needed one for suicide prevention, and I got tasked with that because I was over crisis services, and at that time our other states didn't have robust crisis programs. So we kind of thought it would be a pretty simple little project we would put together and turn it in and be done with it. But it ran through our Center for Clinical Excellence at our research institute. And so what I thought was going to be pretty simple, we had to write a charter, we had to write project plans. And we started just looking on the internet, to be honest, for, what kind of programs were out there. So maybe we could go out, take a program off the shelf and replicate it. And we found pretty quick. Yeah, right. And we found out pretty quickly that, it's not there. We came across the systems and care framework document, which we liked. But it seemed to be a very 30,000 foot view, and we needed like a 1,000 foot view. It was great to suggest have a system for this, but we needed more boots on the ground. Kind of by chance, our Centerstone of Tennessee CEO, Dr. Bob Vero, went to testify in front of Congress for a committee, and he saw his friend Mike Hogan, who I know most of you guys are familiar, with Dr. Mike Hogan. Yeah, love him. And Mike said, have you heard about this kind of call that's going on with 3 departments of mental health in Magellan of Arizona at the time? And could you guys, as a provider, maybe jump on the call? And so that was really the first we had heard of this notion of Zero Suicide that had come out of the Henry Ford Health System. And so we just jumped in, I would say, with both feet, and really a lot of things we had to create because they just weren't there. But we really tried to address all of the pillars that are now what would be made up of the Zero Suicide framework.
Going back in time, what was one of the first things that you noticed wasn't there that needed to be sort of innovated and put in place in the system?
Everything. I mean, we are a very large organization. We are always either the first or second largest behavioral health company in the country. I think now we are the largest. We have, presence. We have a footprint in Tennessee, Indiana, Illinois, Florida, and Kentucky. And we weren't doing a good job. We screened people with a couple of questions. And if they said they were suicidal, we, and we went and got mobile crisis teams to come down and take care of it. So it was very much a bolt-on system. So we would have gotten a D- in my opinion, in hindsight. So we really had a lot of work to do. I think the culture wasn't good around it. People felt like, I tell this story when I do Zero Suicide Academies. about culture is a girl that had used to work for me in the call center had gone to be a therapist a few years ago. And when we first started this work, I saw her in the parking lot at our main office one day where my office is. And she was like, she lives in this town I live in. Our kids go to school together. And she goes, oh, I'll be back up next week. I have to come up and defend a suicide. And it just really stopped me in my tracks and thought, she's a really good person, a really good therapist. And she felt like she had to defend a suicide is appalling. So we had a lot of culture work to do, a lot of EHR work to do to get things embedded in our record and really come up with a system of care, and then a way to monitor what we were doing and do some pretty rapid performance improvement.
So what was one of the very first things, we were talking to Glenn about how now, there's a regular way that you guys report numbers about suicide so that the system can notice things and take action to reduce mortalities. But
Right.
that's a couple of years down the road. So what was one of the first data related things you started putting into place in your EHR?
I think in the EHR, we had data going back to 2000. All the way back to literally the calendar year of 2000 forward, we could tell you about the suicide deaths in our system. We could tell you how old they are, what county they live in, what sex they are, their marital status, their diagnoses, what meds they were on, how often they were seen, who saw them. But we didn't do anything with that data. We weren't mining for it. So I think, the first thing we did was try to come up with a common way that we were going to measure who was counted as a client, because I'd say this, some people said, well, they're either open or they're closed, and after we laugh really hard, we were like, it's not that simple. Our staff don't like to close patients out, because when they do, we call that speaking them up. And you speak them up. As soon as you close them out, they're going to show up the next day, which means you speak them up, right? So our staff don't like to speak people up. And if they close them, it speaks them up and they'll show up and they got to start all over again. So they don't close people.
So I want to just explain to folks who aren't familiar with the clinical work. If you're using an EHR, if you've got a clinic of any sort of any shape, you've got a whole sort of bureaucratic process for opening a case, assigning them to somebody, entering them in the system, certain kinds of notes and assessments and things that you do, and it's fairly time consuming. It can take a couple of hours. And then when you close somebody out, that also takes a couple of hours. And so a lot of people, and this happens in clinics more than at Centerstone, a lot of clinics, the joke is that patients sort of have a sixth sense that you're closing them out, and that they sort of show back up so that you have the maximum amount of bureaucratic work for the minimum amount of clinical benefit. And so clinicians in mental health are often really wary about following a standardized procedure for opening and then after a certain period terminating and closing a patient in the system, just for education's sake, because not everyone is a clinician in the audience. Go ahead, Becky.
Right, so we call that speaking them up. And it's it's a thing, it's true, it's powerful. If you have somebody you don't like, say their name, and tomorrow they're going to call you, or you're going to run into them at Target. So we, that was some of that, like, who were we going to count as a patient? How were we going to confirm that their death actually was a suicide? So we started getting medical examiner reports just to be consistent across the board, knowing that some probably don't get counted that they should, and some probably get counted that shouldn't. But we decided to be standardized and go with medical examiner reports.
Now, can you tell folks about that process? Because a lot of people don't realize, I know this because we do this in VA, but a lot of people don't realize that you can get the medical, or sort of the death investigation report. That's public record. Yeah,
it's public record for about $20. You can ask for it. You make a request. It's online. Pay your money. And we go with, whatever the report says. Most of the time, the kind of hinkiness around is it or isn't it is, overdoses. And with opioid, being such a big deal right now, we just, it helps just to have something standardized.
And by the way, like, Centerstone is really big, right? And so those death investigation reports are really probably variable from state to state or county to county, right?
Sure. Yeah.
So how did you manage that?
We tried to do some educating with some of the MEs in the counties just to say, we're using your data, and if you could try as hard as you can to be thorough and honest, and a little, we cover Moore County, Tennessee. My footprint covers Moore County, Tennessee, population 300. It's the home to Jack Daniel's Distillery. That's the business that occurs there. So it's a very tiny, small town. So a medical examiner might be more likely to put accidental this, or, not want to put that stigma there. But we've tried to speak with them and educate them that it's very helpful for us to know if it was a suicide that it get called that, because a lot of times they would do it to save the family some pain.
And I will say, I don't know that in most cases that actually works, that it saves family pain, but I can understand the dilemma of death investigators in small counties. Definitely can't. I cover a large area as a suicide prevention coordinator. There are small counties with coroners. And sometimes those coroners, their data isn't in an EHR. So do you have somebody who sort of does a standard process at Centerstone?
Well, yeah, we have people that look anytime they see death, but to be honest, a lot of and this is, I don't know any other way to say it, but a lot of our front desk receptionists are really nosy, and they read the obituaries every day.
Yes.
And so they'll get in and they'll type and look. And so a lot of times that's how we find out. So we didn't ask them to do that, but they've just kind of always done it. And so a lot of times that's how we'll hear. And, a lot of times families call and tell us.
Someone is, Anne-Marie, one of our people on our Twitter stream, says, we'd love to have a chat sometime about how to bring zero suicide into feet on the street community coalition language so that we can share. Like, how do we talk about zero suicide in a way that you could discuss in your community? Did you do any of that when you started?
Well, no. And I can tell you, there's I don't go anywhere that somebody doesn't say, this framework is for health and behavioral health care. How do we transpose this into being how do we tweak it and make it applicable for the community? And I know there's a lot. Richard McKeon at SAMHSA is very interested in looking at the community aspect. So I think there's work being done on how to take the pillars, the 7 that are there, and figure out how you modify it a bit, but make it applicable for the community setting. So I think there's work definitely being done in that. And I get asked, every city I go to, I get asked the same question. So it's being done. It's being worked on.
So, and I'm going to turn this over to Bart from some commentary. We usually try to check in about the quarter hour mark, but I will say, like, communities talk about health issues all the time, and they talk about things like traffic deaths in certain areas, or they talk about things like flu outbreaks and how, I remember living in a community that had a massive flu outbreak that we had a really hard time handling. And like, communities do talk about public health stuff. I don't understand how it would be so different to use the same sort of channels to talk about suicide as a public health issue in a community. What do you think about that?
I think that's exactly right. And one of the speakers when I was in Sioux Falls, South Dakota this week, was Maureen Underwood, who does a lot of suicide prevention work. Excuse me. And she was talking about this notion of competent communities. And so if you have a competent community framework, you can use it for anything. You can use it if a hurricane hits your neighborhood. You can use it for a flu outbreak. You can use it for suicide prevention. So I think it is applicable. It's not like it's a certain flavor that only behavioral health and physical health can use. It's definitely a flavor the community can partake in.
Okay, fantastic. Boy, that was quite a bit of introduction, and I still haven't heard all the story that I want to hear. But before we keep going, I'm going to check in with Bart. Bart, you've been paying attention to the Twitter stream. Any thoughts?
Yeah, so there's a bunch of stuff in the Twitter stream. I think I want to focus on this community piece because I'll come back to one of the other questions. But Becky, I don't know if you've noticed this, but when I talk about zero suicide, I often get more traction and more people excited about it that are in the community as opposed to the facilities and agencies that were wanting to actually do zero suicide stuff, right? And so people will hear about zero suicide and they're like, how do I how do I get my hospital to join Zero Suicide? How do I get my clinic to join Zero Suicide? And I'm always struck by the fact that there's this passion in the community to do more, and it's really hard sometimes to engage agencies. You go out and work with a lot of agencies. What do you think what's the best way to approach agencies to get them thinking about Zero Suicide?
I think it's approaching it from a safety standpoint and focusing on it as an error in the system. Just like we don't want to leave a sponge in someone when they have surgery. I don't want you to give me a staph infection if I have to have surgery on my ankle. I mean, it's an error it's a systems failure, and it's a systems failure around safety. And so that's I think the challenge to health and behavioral health is you're obligated to keep people in your system safe.
One of the things that really happens, I think, among mental health professionals, you talked about, I was really struck as a clinician when you talked about defending a suicide, because definitely I see folks at high risk for suicide. I have a small caseload, and that's what I do. And so occasionally we lose patients, which is just heartbreaking and painful.
Right.
And also there's an administrative review, and so there can be sometimes legal actions.
Right.
And so the issue is when you talk about leaving a sponge in somebody, the issue isn't add more paperwork to the doctor's workload or make the doctor have a superhuman memory or things like that. I mean, when you guys talk about adopting zero suicide practices, you're really talking about systemic behaviors that do things like the sponge doesn't get left in because we have all these sort of steps that we follow consistently, right? Can you explain more?
Yeah, so our pathway, I mean, I'll try to keep it to the Cliff Notes version, but it started out with culture change and proclamation from the CEO at the highest level, Centerstone of America, which is our parent company, saying, you know, this is a new day and we're going to do this differently and we're going to do it better. And we all know when you have thousands of employees that work for you, and, you know, a lot of times they see when you throw the spaghetti on the wall, is it going to roll off? Or is it true and you really are going to do this? I think the second thing was having a workforce that felt competent and skilled in being able to even do this work, because most of us in graduate school, in undergrad programs, didn't get any of this. So we had to take on, I mean, we did the workforce survey. We didn't do very well on it. And then my message to everyone was an apology. You know, shame on us, and we're going to do better. And then you kind of could see them perk up a little bit and go, well, maybe this isn't going to go away. And everybody starts rowing the boat in the same directions. And then we had to figure out a way to ID these folks and putting an evidence, you know, informed tool into the EHR, you know, PHQ-9s and Columbia scales and things like that. But then we had to say, okay, once people get put on the grid, once we put them in our pathway, how are they going to be treated differently than if they weren't in the pathway? And that was, you know, some real simple stuff.
To our non-clinical folks, what putting people in the pathway means?
It literally is a program that we open in our system. The patient's names display in red, and it means you're going to get different care. Just like if I went to my primary care physician, and let's say I was diabetic, and they're going, you're not doing so great, we're gonna monitor you differently. And here's a sheet of paper that says how we're gonna monitor you differently. So we do that. We give people an education sheet, we call it, and then we fill out crisis plans with them, and we do means restriction, and we try to see them more frequently. I mean, really parallel to how you would do something in physical health. And then we tried to set things up. And I tell you, I do not underestimate the power of IT resources and the technology folks, because we had them on our committee, and they were some of the people that came up with ideas like, so when someone enters our clinical pathway and exits the pathway, at times it was difficult because a patient may have 2 or 3 providers. They might have a therapist, a case manager, and a psychiatrist. And you were trying to let people know, oh, hey, they're in, hey, they're out. And so they came up with a system that in the record, when someone enters or exits the pathway, a high alert email goes out to any provider that's touched the patient in the last 90 days.
Oh, nice.
Right. So IT came up with that. Then they came up with if a clinical pathway patient that's in the suicide pathway doesn't show up for an appointment, and the clinician calls them and they can't get them on the phone, they go in our system and they mark that they didn't show. It's just a radio button. You click, their name flies over to our high-risk follow-up team in our crisis call center. And the crisis call center follow-up team goes and tracks them down and finds them. And we've averted deaths that way. And then they let you know, so the clinician then goes back and just sees their next patient, and we take that on in the call center and we told people when we gave them the education sheet that that's what would happen. You know, please call us if you can't come, because we're going to be really worried. And so we commenced to tracking them down.
Intervention, right? Like that's what you do with folks and who are in dialectical behavior therapy, because we assume that they're high risk, and we say, if you don't come, I'm going to be worried, because if I cared about you, how could I not find you, right? And we explain we don't do this for all folks who are receiving mental health care, but we do for folks at risk, and that we treat them differently. And that's really not how therapists are trained to behave.
Right. I mean, we've talked to a gentleman that was about to jump off a bridge by making one of those follow-up calls. And I mean, that's, that's why I tell people, 0 is 0 is 0. We try to get to 0 today, and then we'll get up tomorrow and try to get to 0. And so those are kind of some of the pillars we addressed, and then really mining the data that we have and looking to see if there's issues. We found out last fall when we looked at our suicide death rates, our analytics department discovered that 42% of the people dying by suicide were receiving only medication from us. They weren't getting any other service. That was an issue. That's a big, 42% is a lot. And so we had to kind of put the brake on and convene a group to try to address that. And so we put some things in place. And sure enough, this calendar year, we've only had one.
And that's down from how many?
Probably year to date, maybe 12.
So one of the things that's really, really difficult when we're dealing with the scales of suicide is that the base rate of deaths is really, really low. And so sometimes we talk not only about changes in deaths, do you guys ever talk about changes in attempt rates?
Well, let me tell you the difficulty I think we're not odd. I think this is for everyone. Attempts are very hard for us to track. And we don't feel like we track it well enough to talk about it much. But the only way we have to track it is for people to tell. It's a self-report. And, or do you just go with things that required medical attention? So it's so fuzzy and not very clear. We don't do much. I mean, we try to go upstream. We look at all attempts that get reported, which, they always get reported. And we look at them in our monthly meeting where we review any suicide deaths and any suicide attempts. But it's fuzzy, and I think it's hard. And unless you can get insurance companies to send you data based on, ER codes, it's very hard. And then still, let's just say we did that, we still have a pretty large uninsured population. So we don't have an insurance company to get that data from. So it's one of the fuzzier areas for us. We review them, but we don't put data out on that because we don't feel real confident with it.
So, I mean, that's really interesting because, I mean, that's not a Centerstone problem. That's like a big mental health system problem. A huge
problem.
Right, because if somebody has a heart attack and if somebody dies of cardiac arrest, those things get coded in healthcare. And so systems can know about those things. We have suicide attempts where somebody is much, much closer to fatality due to their mental illness. Like that's really important, and that there's no good systemic way to sort of catch that and put that in a place where we can track that and respond is a pretty big problem. And I will say, because you're totally right about self-report, and a lot of folks who attempt suicide don't seek medical care.
Right.
At VA, we rely on self-report, or if somebody goes and has a rescue, we get notified or whatever. And then we do something called a suicide behavior report note. And then we have like a standardized, way of noting some information about the suicide attempt. That we do look at, but it is not, you're totally right. These are not ideal data systems. These are just the first ones that people tried to be really systemic about.
Yeah, it's definitely an area for improvement. I don't know how we address it. We're not doing a good job with it. So we don't talk about it much. We don't feel good about the data. I don't think it's accurate. So we look at suicide deaths, we feel good about. But the attempts, not so much.
So if I can make you queen of the world,
yeah,
for 1 week, and you could make any decrees about suicide and data for all healthcare systems, what are some things that you think would be great next steps to make this a little bit better?
I think people need to know how many suicides they have in any given month. We do a rolling 12-month count, so it's a pot of people, like how many people have died in your system in the last 12 months. We don't do a January to December, we roll, so it's always accurate. So come Tuesday, when it's November 1st, October of 15, any suicide deaths we have will roll out of the pot. In October of 16, if we had any, will roll in the pot. And then you calculate a rate. So I think those three pieces of data are key. But I think there's so much information. If you have electronic health records, which lots of people do, most people do, there's lots of information to mine in there, and you need to get in and do that. And you need to know what ages they are and what races they are and what meds they were on and what diagnoses they had and what counties they lived in. What services were they receiving and how often were they coming in for care? We need to know that. I think the second set of data is not so much about the patient, but about the providers. And you have to have fidelity data. So if you build this system, is it really working? And are you, like in our system, if I put you in the pathway, I'm supposed to talk to a friend or family member about means restriction. I ask them to call me back in the same day and confirm they were secured. And if I don't get that phone call, I'm supposed to call them. Do we do that? Did we do it? And we got to get in and look. And so each of our service lines gets a report card grade every month that our QI department came up with. And so they can see on a fidelity scale that they were a C for the month or an A for the month or an F. I mean, how did they do? And if they didn't do well, what were the columns that brought it down? Were they not doing means restriction the way they should? Or were they not getting people in weekly because their schedules are too busy and they didn't shuffle them around and get this patient in? And they don't like to get lower grades. They're pretty competitive about it.
Yeah, by the time you get that license, you've learned that lesson, right?
Right. Like they don't like, I mean, we also, each of our service lines and locations have a mentor, and it's someone from our suicide prevention committee. Like I mentor the clinic that's closest to my office. And last month they were at a C+, and they didn't like it. And so when I went over and went to one of their meetings, we had to kind of talk about what was the column that caused them to not do so well. And I had to make sure they understood, every single thing they're supposed to be doing.
So I regularly in the position of giving a system feedback about whether or not they're doing things, and also about making changes. So for example, one change that we made in the last few months was on our safety plan notes, we have means restriction buttons, and we have those on our suicide risk assessment notes that you can't get out of the note unless you sort of check that I've talked about firearms, for example, to make sure, because the facts are that relying on human memory is like, humans are fallible, but this checklist thing takes a lot of that cognitive burden of me off of remembering to do everything right. And what we saw was we had a lot more conversation about means restrictions, and we started seeing it in the notes more often. Do you see similar kinds of things when you're doing these kinds of interventions with your staff?
Yeah, so what we found is most of the clinicians don't have anyone in the clinical pathway for suicide prevention, and if they do, they have one or two, which is great because we have so many staff. It's not like one person has 20 people. But the downside to that is they don't put someone in often enough that they remember everything to do. So we had to create this paper packet that said, pull the packet out if they go in. But we just are in the process now of electronic, what would be the word, Bart? Electronifying, putting it into the electronic health record so that that paper packet now is electronic. So if you go on the pathway, it's going to say, hey, goofball, make sure you do A, B, C, D, and E, and you got to check that stuff off. And the beauty of electronic health records are this, like you just said, you can force things to happen or you can't go any further. So sometimes you can take care of fidelity on your own by just forcing it and not allowing it to be skipped.
So there are a couple comments about the way that you're flagging in the record. I know we do it at VA, and I would love for you to address this. So Nathan, who is an alum who's done the show, just like you have, and actually Desiree was also an alum. Nathan says, we need protocols in primary care regarding mental health and suicidal ideation. We flag patient records for medical conditions. Let's do the same for mental health. And then Desiree's stage with lived experience community brings a different perspective. She says, I know some places look at it from a discrimination standpoint and keep it confidential, like HIV or AIDS status.
I mean, I think physical health and behavioral health have got to be talking. And if you are at highest risk to die by suicide, we've got to somehow in the record be able to see that. I mean, in our record, it's red. I know some very, very integrated behavioral and physical health can see that. So if someone comes in for, podiatry appointment or whatever, any kind of physical, the clinician, the medical provider can see because of the color coding. Oh gosh, Bart's come in and I'm seeing him for a respiratory issue, but I also know that he must currently be high risk for suicide because he's showing up as red. And it gives us more opportunity. I mean, just like when we're
not putting like a badge on them that says this person's about ready to explode. But all of the providers and the people who are providing care have an alert, and they've got and the flag is not to out patients to other people. The flag is to inform the staff that this person is being given a specific treatment protocol.
Right.
Which you would do, by the way, any other health condition.
Right. I mean, I would hope, they probably don't have this, but if you really thought somebody is close to falling over dead of a heart attack or an aneurysm, it'd be really great if they had one of those. I mean, we've got to take more advantage of the opportunities, especially in physical health. I mean, when you look at the stat, and that's the stat everybody throws out about the 45% or whatever it is that see their medical provider before they die by suicide in the 30 days prior to death. And I think it's 19% for behavioral health. We've got to get physical health in the game. They see folks way more than we do. And we've got to get them on the team and out on the field with us.
Absolutely. We have a flag on the records, just like we do for high risk for suicide. We have one for falls. If this is a patient at risk of falling in the clinic, like this is, and they get special accommodations. It's just how we do it.
Right.
And so, for example, we don't want to be a lot at VA. We may see a patient a couple times for routine care a year. If they get this high risk for suicide flag, we don't want their primary care doctor giving them 3 months worth of medications. We want to give them a smaller amount so that their ability to overdose, and if they're not doing well, we don't want to give them means to die. I mean, it's basic things like that.
And the only thing, there are some records where a patient is red in the record when they're highly suicidal. And then if they're no longer at high risk, they're yellow. And it indicates, and yellow indicates to everyone in that system, this is a person who has been high risk for suicide. I have heard I've heard not a lot, but a little bit of debate about people saying, I don't want to be tagged that way. I don't want forever and a day to be tagged as someone. And then I've heard other people say it's significant. It's history. It doesn't mean anything except, hey, at some point they were high for suicide, I've heard a little bit of debate on having some kind of color code when they come out. We don't have it when they come out, but I know some systems do.
Des Stage says, I would love for this color coding system to work, but it's also kind of terrifying given the number of providers who are untrained. And of course, I don't know what your response is, Becky, but my response is, let's train providers better. Let's not do nothing if there's prejudice and discrimination. Let's train providers better.
Yeah, I would rather. I would rather train folks than not color code it just because they're not trained. Because it's a sweet spot. If I come in because I've got bronchitis, and that clinician who's medical, but I didn't go to my therapy appointment, and I don't have a med appointment for my psychiatrist for another 2 months. But I'm high risk for suicide. I'm not showing up for appointments on the behavioral health side, but I went in because I've got strep throat or bronchitis. That's a sweet spot. We got to get them where we can, and I'm with you. Let's train them on what to do to be able to access resources.
Yep, and then Desiree Stage's partner, Fel, says it feels like everything out there is about flagging, tagging, announcing, then what? And I think, Becky, that's what you're saying, which is then we have a treatment protocol. So the flag isn't just meaningless, that there is something that the system's obligated to do if it's there, and it's standardized. And then what Becky is saying is that then they look at their data and they make changes to their system or changes to their care to get that mortality rate down.
Yeah, and to me, flagging is not to be gossipy.
Mm-hmm.
It's not to gossip and go, ooh, guess what?
Mm-hmm.
I'm going to make you privy to something you weren't privy to before. Isn't that a juicy piece of information? That's, the intent is to be inclusive and to treat people as a whole person. So if, just like, and flip it, it's very helpful on the behavioral health side if we know what's going on the medical side. And so we should be asking, how's your diabetes? How's your diabetes? How's your high blood pressure? How's your fill in the blank? We got to look at people as a whole and not split them in half.
Like my high risk list has an inordinate number of patients who have migraines, blood sugar regulation issues, and sleep problems. And so one of the things I'm wanting, if they're flagged as high risk, I'm wanting their, FELDES, and we actually have now several people commenting on this. One of the things I want their primary care doctor to do is we need to find out why the migraine treatment is not working. We need to find out what we should do differently about their sleep. We need to find out what changes that as their therapist we need to coach, or so that they can get their blood sugar regulated. That is super important. If you aren't sleeping, if your blood sugar is not regulated, it's really hard for you to regulate your mood and cope, and you're not going to get off the high risk list. We're not going to start to move towards recovery.
Right. Amen.
Is that what you're saying?
Absolutely.
So our last question for the evening is to talk a little bit about Centerstone and media, and that Centerstone's been doing media about zero suicide and about how they're changing the system. Do you want to talk a little bit about that?
You broke up. Could you say it again? Because I didn't hear what you said.
Tell us a little bit about what Centerstone has been doing with media about suicide.
We haven't seen it so much as an external marketing campaign, nor should anyone else. So it's not really we don't have posters in the lobby, and we don't proclaim ourselves that. It's more of an internal. So I think any of the media we have had has been where people approach us and want to hear, just kind of what our journey has been and what the results have been. And so we've, responded to some media requests. The hardest thing has been when they want us to find someone for them to talk to, because we are pretty, private about that and understand people are fragile. So I think any of the media stuff is because I've talked about things at an academy, or the Suicide Prevention Resource Center may get called and say, hey, is there a couple of entities you could direct us to, or who are doing this work? But we haven't done any. It's not really something it's not really intended or supposed to be an external media campaign.
So Centerstone is really doing, kind of really similar to SPSM. You're doing sort of expert to expert media. So you're talking to other orgs look, we've done this. If you want to learn how to do this, here we are, and here's kind of what's been going on. Give us a call. right?
Yeah, and that's really been in two ways. I mean, a lot has been my teaching at Zero Suicide Academies that are put on by the Suicide Prevention Resource Center. And then it's been some suicide annual conferences asking me I mean, I was in Sioux Falls 2 days ago, and it was just their state conference, and they just wanted to hear a little bit about zero suicide, what the pillars are, how we addressed some of the things in the pillars, and then, you know, did we have any luck with that? So that's been the kind of the way it's gone for us in terms of getting the word out.
Well, getting down to 1 death in a calendar year might be a little bit more than luck. Really quickly, we've got a few minutes left before special surprise. Guys, we have like a little bit of speaking meeting. We will have a special surprise. But there was something that came up in the like the beginning, like the warm-up, that I want to talk about. So one of the things that the VA is doing is the Reach Vet program, where we've looked at our EHR data. We've talked about mining, you know, getting a relationship with IT, mining your data, and then using that to predict who's at risk. Because right now, the current state is we say, hey, are you suicidal? And if you say yes, we might have some stuff for you. But we have folks who die by suicide that we ask that question and they say no. As a matter of fact, we're getting to the point in our system where that's our most common scenario for people who die by suicide. So what is it that people are starting to do? Although my understanding is it's not developed enough that good clinical action can be taken. But can you tell a little bit about what you're doing with your IT department?
Yeah, so last year, and we haven't really talked about this much because it still seems to be such an infancy, but we have 3 managed care companies in Tennessee for our Medicaid program. It's called TennCare. And 2 of them approached us and said, we'd like to send you some data and see if you could develop an algorithm and see if you could predict inpatient hospital stays. And so they developed, it's called Trees. I don't really understand it. They did a big PowerPoint and I didn't get
Lane
it.
Coppersmith talked to her, you know, and he did understand, just so that you know. That's Becky's job is not to be the data science person, but go ahead.
No, so they put it through, and I guess they predicted 37% of the time they could have predicted that this person was going to go in the hospital. And I guess in the nerd world, 37% was great, and they just were very excited that they got it so close. I guess 37% is good. So we asked them to take, at the current time, our suicide death names. So we had X amount of people that were in the rolling 12-month count. And we asked them just to run it through the algorithm and see if it would have picked up any of the suicides. And if when it goes through these trees and it catches on things, whatever, the way they explained it. So we had them run it through, and it picked up that we could have predicted ahead of time 50% of the people would have killed themselves.
And of note, there could be some false positives, but still, like, considering the very low base rate and very high sort of impact that this is somebody's life or death issue, and we might be able to predict their risk of dying. That is a huge deal. Even if this is only in developmental stages or in its infancy, that is a really big deal.
Yeah.
Right?
So, but
what could you do differently? Go ahead.
I mean, we've talked to them about trying to, you know, further that work along, but it's just so, I mean, and I, again, am not the expert and I don't understand a lot of it, but it's so complicated and it's such a needle in a haystack from, you know, when we talk to them about how the difficulty of really putting predictive modeling in place. So we are definitely not experts on it. I mean, that was our experience with it, was just running it through an algorithm that had been developed for something else. But I would love if our electronic health record could pick up some kind of, if we have information on you in our medical record, if it could pick up that you are at higher risk and we could know that before you even open your mouth. When your butt sits in the chair, if we had some kind of way to say, hey, clinician, sit up a little bit straighter and listen to this person a little bit harder, it would be great.
Exactly.
I don't know when we'll get there or if we ever get there. And I don't know if we're the ones that are going to get there. It may be somebody else that, like the VA, I think, has done way more work around this than we have.
And of note, like in other healthcare conditions, you know, they do things like this. So if you go to, like, and I go to a primary care meeting once a week in our primary care clinic, and I've learned a lot of things about other parts of the body. I've learned things about predicting, or, you know, about blood sugar and diabetes management on your panel, or this is how we do these cancer screenings, or this is what an anal fistula is, and these are our different routes of treatment. The issue is that in all other areas of medicine, there are medical standards, and they're highly regulated. They're not sort of an artistic sort of like your spidey sense is tingling, so onto the suicide risk list they go. But it's much more like that we have a data-driven way of looking at your panel and noting who needs special treatment. And I mean, this is what you're saying, right, Becky? Which is we could be
Right.
using our data and start doing this for suicide.
Right.
And that's super cool. And what I'm really excited about is that major large healthcare systems are just starting to think that way. And then, of course, what we're going to need to do is have the data science that goes with that, and talk about the ethics that go with that, and talk about exactly what our Twitter stream's talking about, which is then what is the treatment plan. So now that we know who's getting a sponge left in them, and we can even predict which patients are more at risk of getting a sponge left in them, now what do we do, right?
Right. Exactly.
So we're going to, Becky, I don't know if you know who Lisa Klein is, but she is an artist, and she is a filmmaker working on a documentary about suicide. And she just came to the SPSM community yesterday afternoon with some important news. So we're just going to go to her for a quick announcement, and then we're going to circle back to final thoughts. Lisa, okay. I've got you on. Can you unmute and share with everybody your good news? Oh, did we just lose Lisa?
She was there. Lisa. She's there, then she's gone.
She was there, she's gone. Bart, while Tony's working on that, you've been watching the feed. It's going too fast. Can you tell us a little bit about what's been happening in the feed?
So a lot of conversation in the feed about how people want action now, right? Suicide is happening, the rate's going up, and that all of these things that we're talking about are amazing. And how do we get this all over the place? And how do we get everybody trained and get all this stuff done, right? Which is, you know, the huge question. For me, Becky, what Centerstone has done is pulled all these pieces together, the IT piece, the training piece, using the electronic health record, and creating a system that has checks and balances that is just so powerful. And you guys have had real success with it. Your suicide rate has come down since you started doing this.
Right.
And so when you think, when you tell people about why it's important, and we know it's about safety and care, the system that you put in place saves lives. And that's why I use it as a model. When people are talking about zero suicide, I say, check out what Centerstone is doing. For you, what are you most proud of at this point? What pieces, what are the pieces you think have been the most effective in terms of bringing down the rate? If you had to narrow it down to a couple of things, what do you think's been the most effective pieces? If people are going to do a couple of things, what would those things be?
I think it's got to be embedded in the system in a way that it's baked in, and it's got to really be, and I know it sounds corny sometimes, but it has to be really woven into the fabric of everything that you do, and it's important, and you talk about it all the time. And I'll tell you like a 30-second story. I had a guy come into my office a month or 2 or 3 ago that's a business office person, and he's a supervisor, and he said, I've got an employee that's not doing well, and I don't know what to do. Can you help me? And I said, okay, kind of what's going on? He goes, well, I think it's really bad. And I said, well, how bad? He goes, well, I asked her, how bad is it? And she said, it's Becky Stoll bad.
Oh, wow.
And for a minute, I really didn't understand what he meant. And then it kind of dawned on me, this is a business office, you know, line worker type person, and we talk about it so much. This is not a clinical person. This is somebody pushing bills out the door or something like that. And she knew enough to equate my name, because I'm, you know, all the communications come from me, and she knew enough to convey to him that she was suicidal by saying something like that. So I think culture is It's just got to be something you're talking about constantly and all the time. I think you got to figure out how to put people on the grid. And then I think you got to, to me, the key has been you got to make sure somebody is paying attention and monitoring the care that these folks are receiving while they're on the grid and at highest risk.
And Becky, you hit on a key point that it's not just your clinicians that are involved in zero suicide. It's got to be everybody in the company, right? So that everybody has some level of involvement, some level of training and communication around what we're doing to prevent suicide. And how do you guys do that with Centerstone?
I mean, we made a PowerPoint that all new hires have to watch that says, if you work here, we take this really seriously, and here's like what we do. And one of those is for clinicians. Anybody that interacts with patients, they have to watch the clinical one. And everybody else, from, it doesn't matter what you do in our system, you have to watch this PowerPoint presentation. And it says we take this seriously. I mean, it's the utmost important thing that we do as an agency, because everything else we do won't matter if the people coming to see us die by suicide. We don't get to put them in homeless programs. We don't get to put them in residential and case management and therapy, and we don't get to do anything if they're dead.
Absolutely.
It's amazing because it gives it the culture. Everybody in the agency has a role to play, and it's important, and you emphasize that. Thank you, Becky. That was awesome.
Yep.
I'm super thrilled that you've been on. I've learned a lot, and I have to tell you, Bart, great call on this. Becky, what a pleasure. We're going to have a brief announcement from our sponsors, sort of. Lisa, can you come on? Are you on and solid? Can you make your fancy announcement?
I think, am I on right now?
You are.
Yes, you're on.
Are you hear me?
Yep.
Yes.
Awesome.
All right. So, been working on this little film for like 3 years or something like that.
Woo-hoo!
And we're trying to get this thing going. But in the meantime, we sort of have this trailer. And I really wanted, I was trying to figure out, like, am I talking really loud? I'm hearing myself
You're
loud.
perfect. You're perfect.
I like hearing that I'm perfect. So what we're doing is we're figuring out, well, how do we launch it? What do we do? And I'm thinking SPSM, duh. So that's where I kind of wanted to premiere it. So what I'm going to do is I'm going to press a button on this phone, and I'll put it on Twitter, and I'll do it that way. And is that the best way to do it?
Absolutely. Tweet out. So everyone, Lisa's tweeting out the link to the new trailer, like right now. You heard it here first. Hashtag SPSM, right?
I hashtagged SPSM. I did the whole thing. Brand new S word, blah, blah, blah. Hashtag SPSM. I would love for you, everybody, anybody, you guys are my SPSM family. So if anybody can just let me know what you think. And I learned a lot about zero suicide, by the way, Becky.
Awesome.
That was kind of awesome. So thank you.
So,
I've been listening the whole time. So I would just love to hear what people think.
About Thunderclap. Are you going to try Thunderclap this week?
I guess. I mean, I have to learn how to do it. I don't know how to do it. I tried
it. Like, you just got to sign in and design a couple messages and invite us. You've got to do this.
Really?
We're going to do this together.
Let me talk
We're going to do this together. So SPSM, watch the trailer. Share it with your networks. Be on
Share it with everyone.
On Facebook and on Twitter, because we're going to try Thunderclap to help the trailer, because this is now getting submitted to all the festivals and things like that. So this is the time. This is the moment, folks.
Thank you. Thank you. Thank you. I'm
Thanks
so
for
excited
joining us, Lisa.
Thank you.
Tweet on. So, Becky, this is the time on Sprockets where we talk about final thoughts. I know.
Yeah.
I just don't want to waste this little bit of space I have on the screen, right? Here we go.
Yeah, right. I think
so Becky, go ahead.
Yeah, I mean, I think the work that's left to be done is, and somebody may have said that in a tweet, I think, is we've got to do a lot of work. I think we're doing better at getting behavioral health ready to take on patients that are high risk for suicide. I used to be worried a few years ago that we were telling people to come to the behavioral health system and we had a workforce that wasn't ready. And I don't know that they're still 100% ready, but I think we're better than we were. But I think physical health is just ill prepared. They don't want to screen because they're afraid of what people are going to say. They don't know where to send them. But I think we've got a lot to do in that space to get physical health, to take advantage of the opportunity for that little sweet spot that they have when people come to see them. And I think the other is back to what we started talking about at the beginning. We've got to figure out this zero suicide framework for the community setting, because most people dying by suicide in this country are not touching the behavioral health system. So we got to go to them. And I think employers, I love Sally's Spencer Thomas's stuff, because we've got, in my opinion, instead of trying to figure out where people go and trying to hit them in their communities, most people work. Not everybody, but most people. And I think we've really got to start engaging employers in some of this dialogue. So that's probably my musings for the evening.
Community and engage employers, because most folks who are at risk of dying by suicide aren't coming to me therapist.
Right. And engage physical health providers.
Absolutely. Dr. Bart Andrews, final thoughts for the evening.
Final thoughts, Becky. Thank you so much for joining the program. Hearing you walk through, I mean, it's really interesting. People talk about zero suicide and they don't realize what that really means. And you did a beautiful job of walking through some of the system changes that you've put in place at your agency, and their life-saving system changes that are in place, right? And I love the fact that when you bring in IT, and IT has ideas, and you work those things in. So you just really model so well what it looks like when a multidisciplinary, agency-wide initiative like Zero Suicide is rolled out, and that it works. And you represent that so well. So here's to having a lot more Centerstones out there doing the things that you guys are doing. And I just appreciate your wisdom as always. I've learned so much from you over the years. So thank you so much, Becky.
Of course. Sure thing.
Oh my gosh, this is exactly, we were ending on the mark at the top of the hour. This is at Doc Foreman. Final thought for the night. You can't do anything until you start counting the numbers and you start looking at the numbers. You can't fix a system unless you take a step back and look at the system. That is what Zero Suicide is about, understanding system changes in ways that are going to save lives. It is not about cracking the whip on therapists and blaming them for everything. It is about making systems more accountable for, engaging in life-saving systemic behaviors. We are super thrilled that Becky's here to talk about data and to talk about system change. We want you to all be on the lookout for the thunderclap, because we're going to make this happen. Everybody have a great week. Come back for SPSM chat next Sunday. It will be at 9 p.m. We're going to be chatting about Snapchat. We have Hannah Moak, who's so fabulous. We have Katie Hardy, also so fabulous, SPSM alums who understand the Snapchat space. They're going to be walking us through a little bit of how we can use it effectively. And we have a special secret guest who is on Twitter doing Twitter chats about effective use of Snapchat. Super excited. We will see you next week. Everyone have a great week. Bye-bye.
Bye, everybody.
Bye.
Boo.